Okay, hi everyone. I want to thank the audience, thanks the panelists for a beautiful presentation. So the topic of discussion today is the distension-contraction plots of the esophagus and how they relate to functional dysphagia, okay, by using a routine clinical manometry protocol. Now, a lot of research has been done throughout the years concerning the prevalence of normal esophageal manometry in dysphagia patients. The original studies by Cutts and Castell in 1987, they had like 47% of patients referred, they were like classified as normal. Work by Pandolfino-Carrillas in 2008, 25.6% of these patients were classified as being normal, but they had dysphagia symptoms. And our work recently published in 2023 that we see like 38% of patients who are referred to us, they show, they're based on the Chicago 4.0, everything is normal, but they still have dysphagia symptoms. So what is peristalsis? It's like if you have a bolus and you think the bolus is a rock and the contraction is like a bulldozer, you should have a distension in front of the bolus ahead of the contraction behind it. Now, in the normal esophagus, the lumen kind of distends as the bolus is moving down the length of the esophagus, right? So you have initial contraction behind the bolus, distension in front of the bolus, and you have a normal transit of the bolus throughout the esophagus. Now, what regular manometry does, actually, if the takeaway of this presentation is like we are missing half of the story, okay? So what we're measuring with manometry just measures the contraction phase of peristalsis. So I'm going to give you a background of the presentation. Esophageal peristalsis, it has initial inhibition followed by contraction. HRMs just measure the contraction phase of the peristaltic phase. Now, probably a decade ago, we developed a method of calculating cross-sectional area from impedance measurements, whether it's two saline or single saline. And we believe that this luminal distension, or luminal CSA, is an indirect or surrogate marker of inhibition phase of the peristalsis. I'm just going to say distension, because then you can argue about the active and passive elements, but let's just say distension. So the protocol we used in our original studies were 10 milliliters of half normal saline in the -15 Trendelenburg position. We wanted to see whether actually we can do the same thing with the 5 cc in the supine, like a routine clinical manometry procedure. If it's, we will find differences between the groups. So the goal was to see if there are any differences in the distension contraction parameters of peristaltics in patients with functional dysphagia. And we used a 5 milliliters bolus of half normal saline swallowed in the supine position. So we had 20 asymptomatic subjects and 20 patients with functional dysphagia score larger than 10. So after the procedure was carried out, the distension contraction parameters were extracted. The first one was T1, which is the difference between the onset of the swallow, the pharyngeal opening, 2 peak distension in each channel. Then you have the peak luminal CSA. Then you have peak contraction pressure. And you have the area under the curve of both the pressure and distension curves. So this is one way to visualize distension and contraction. The distension appears in blue, followed by the contraction appears in green. This is 5 ml supine. You can do the same thing in the -15. As you see, the pressure pattern remains the same, although we have a bit of an increase in pressure, but a pattern of distension. And you see the distension is walks closer to the contraction as it traverses the length of the esophagus. And this is the original study with the 10 ml in the supine and 10 ml in the -15 position. There's another way of visualizing this. This way you will have the manometry as heat maps, but you can have the distension contractions, the distension as waveform, okay? So I'm just showing you different ways you can visualize this. And now this is actually a favorite for the physicians because it looks like a barium swallow. So you can actually have cylindrical plots of this distension. So you have the upper one is in the supine 10 cc and the lower one is in the TB position. You can see the contraction waveform. So with the red, with the higher contraction values, and you can see the distension ahead of the bolus, and you can see every 0.03 seconds as the bolus is going all the way down the length of the esophagus. You can see the same in the TB position. Of course, there is more pressurization, so you see higher values of pressure. And this is there are 3 different ways of visualizing this distension-contraction waves. Now, as I mentioned earlier, one of the parameters that we measured is T1. And T1 is the time it takes from the onset of the swallow, of the pharyngeal opening, till the peak distension. And you can have the same thing for peak pressure. Now, before I get to the results, I just want to actually throw in a sample case. We have that 53-year-old female. She had 2 years of symptoms of dysphagia and 3 years of symptoms of heartburn. And the symptoms happen every day. She had difficulty swallowing solids compared to liquids. She didn't have any weight loss, normal endoscopy, barium swallow, and a high dysphagia score of 14. So the radiologist said that a few tertiary contractions were noted, no evidence of reflux, and a 13 millimeter barium tablet passed easily through the stomach. Actually, she had a normal biopsy. And this is the endoscopy of the upper esophagus and the the distal esophagus near the Z line. She had also normal endoscopy. So this is actually her HRM. Based on Chicago 4.0, normal, a beautiful opening at the LES. Even when you superimpose the impedance as one shade of purple, she had normal bolus clearance. Now, I want you to pay attention to this. So this is 4 swallows of a normal subject, okay? So you see the distension as red and the contraction with blue. So 4 distinctive swallows, right? Now I'm going to show you the same subject, the same patient, the 53-year-old lady. So check this out. So you see the patterns of contraction are very similar to those of normals, right? Now look at the distension. You see that? How it differs from normal? And you can display it in another way. This is the same normal 4 swallows, and this is the one from the female subject. You see the irregular distension? I previously worked on the ECG, so I call it the arrhythmia of the esophagus. So you can have the same thing here. Visualize distension contraction. This is of a normal. You see the contraction and the distension, and the bolus is going down the esophagus. This is the female subject. You see the bolus arrived at the distal end much faster than the contraction phase is catching up. So they have a kind of a lower T1, okay? So this is a comparison of 20 normal and 20 patients. So if you compare the pressure waves, if you calculate the area under the pressure waves, so you can see that there were no statistical differences between the pressure sums. But T1, so if you segment the esophagus into 4 points with this one with the proximal and this one like the distal, distally the T1 is lower in the functional dysphagia patients. This as to cross-sectional area, normals have higher cross-sectional areas compared to functional dysphagia patients, and the flow was higher in functional dysphagia subjects compared to normals. So in summary, so the T1, that's the time of arrival of the bolus, okay? From the pharyngeal opening to peak distension, and the bolus flow was faster in functional dysphagia patients compared to normals. Peak cross-sectional area of the distal esophagus is smaller in functional dysphagia. They don't distend as well. Now, which actually I found some of your results in the G junction kind of interesting too, which kind of actually pointing to the similar direction. And there is no difference in the peak contraction pressure and AUC contraction between the two groups because pressures are normal. Now, going back to the initial picture, so what is peristalsis? You have to have distension ahead of bolus, and because if you have like a narrow, let's say, road, there's no way you can push the rock, right? There's no space, so there should be proper distension of the esophagus. But what happens in dysphagia, like, a nutcracker esophagus or egg, it seems, actually this has been confirmed because we also do intraluminal ultrasound. So right ahead of the bolus, there's like a narrowing of the esophagus for some reason. And similar enough, you have achalasia 3. It's actually more interesting pattern actually observed in the ultrasound. So it's like a segmental kind of thing. So right ahead of the bolus, you have a distension, but more distantly, you have a narrowing. So in conclusion, based on the results we saw, we have faster bolus flow velocity, a shorter time to travel to distal esophagus, and a smaller luminal CSA of the esophagus. This suggests a narrower lumen esophagus during peristalsis in functional dysphagia patients. And similar to our previous study, actually you can do the same, just use the 5 ml supine position, and you can actually found statistical differences. So you can do your routine normal clinic, and you can get these distension contraction plots and add this as a complementary element to your diagnosis. So distension contraction plots can distinguish patients with functional dysphagia from normal subjects and should be, this is the belief of Dr. Mittal. I just want to give a shout out to him. Should be the standard of esophageal motor function assessment. Thank you.